the rest of the anterior segments were within the normal limits. The fundus examination in the right eye showed the disc had pallid disc edema with the blurring of the margins, and the vessels had a generalized mild arteriolar attenuation. In the left eye fundus was the disc was normal, but the vessels had mild arteriolar attenuation. And then we asked for the fields. The HFA30-2 showed the right eye inferior altitudinal field defect, while the left eye was normal. And the systemic investigations were done. The MRI brain returned normal. TC, DC, ESR, CRP were normal. And the diagnosis, we came with the diagnosis of right eye non-arthritic AION and both eyes grade 1 hypertensive retinopathy. The treatment of the strict hypertension and cholesterol control was advised, and the treatment was started. And the patient was also started on trial of oral steroids and tapered over the period of 8 weeks. So on follow-up, the disc edema in the right eye gradually reduced after the trial of steroids, and even in the field, it had a slight improvement. So the discussion is, it occurs in young patients as a result of underlying condition predisposing the patient to vascular insufficiency. The literature says 10.5 to 12.5% of the patients are less than 45 years, and the young patients, they have a higher risk of fellow eye involvement than the older patients, and the young patients have a better visual acuity outcome also. Among the risks given, our patient had a hypertension and hyperlipidemia, which is seen in the top of the list. And regarding the treatment, there is no generally accepted treatment for NAION. The pathophysiology remains elusive. So the treatment options include empirical and the agents to act on thrombosis, on the blood vessels, on the disc edema, or presumed to have a neuroprotective effect. But using the literature, we came to know that systemic corticosteroids improved the visual acuity in 70% of the patients and the visual field in 40% of the patients, and we went with it. So in conclusion, the younger patients, they have a better visual acuity outcome and a higher propensity for bilateral involvement. So the NAION should be considered in the differential diagnosis of younger patients with a painless optic neuropathy with the disc edema at the presentation. These patients require a thorough systemic evaluation for underlying vascular risk factors to be identified. And these are my references. Thank you.
Yeah, nice presentation, Abhishek. Just like to ask, what's the difference? How do you know, like whether it's a arthritic AION or NAION?
Here the age presentation is usually more delayed in the arthritic one, and here the underlying causes are like only the risk factors, the systemic hypertension and hypercholesterolemia were seen, ma'am.
No, actually history-wise also, if you feel arthritic, mostly associated with giant cell arthritis. So patient will complain of usually headache. Severe headache, jaw claudication, one side pain, and superior temporal artery will be...
No such complaint.
But still, you should ask about that. Yes, but fundus finding, how you know? Whether arthritic or non-arthritic, any difference? Disc finding?
It was unilateral, and it was like one pallid disc edema was seen, and the RAPD also was there. So
no, disc usually in case of arthritic variety, it is pallid disc edema. Yes. While in non-arthritic variety, it will be hyperemic disc edema. That is the main difference between the two. Okay, nice presentation.
Thank you.
Thank you.
A 43-year-old male who has a history of chronic myeloid leukemia, which was diagnosed 6 years back, came to our OPD with a complaint of sudden onset defective vision of 4 days duration. He was on treatment with tab imatinib 400 mg daily once since his diagnosis. He had no history of any other comorbidities and no history of any other drug intake. He also had a history of slight pain on eye movements. On examination, his right eye was absolutely normal, but in the left eye, the vision was 1 meter counting fingers. The color vision was defective and the pupil showed an RAPD. On fundus examination, we could see that there was disc edema in the left eye, and the field showed a depression, and the macula was normal. And we did a VEP, and that showed a delayed potential of P100 in the left eye. An MRI was done, and there was intraorbital enhancement of intraorbital portion of the left optic nerve was swollen with increased signal intensity and contrast enhancement, but there was no other evidence of demyelination or tumor infiltration or cerebral venous sinus thrombosis. So we came to a provisional diagnosis of left optic neuritis, and the tab imatinib was stopped for this patient, and he was started on injection methylprednisolone 500 mg IV BD. And within 1 week, his vision became 6 and the disc edema completely resolved. So he was converted to oral steroids and tab imatinib and discharged, and tab imatinib was restarted after 1 month. But soon after restarting imatinib, within 7 days, the patient's vision again dropped to 612 and the disc edema reappeared. So this time we again admitted the patient, tab imatinib was stopped, but we decided to skip IV methylpred and the patient was kept under observation. And in 10 days, the disc edema completely resolved and the vision became 6/6, but the field effect persisted. So the final diagnosis we reached is imatinib-induced optic neuropathy, which was of late onset. And imatinib, as we know, is a selective inhibitor of BCR-ABL tyrosine kinase, which is used in the treatment of chronic myelogenous leukemia, acute lymphoblastic leukemia, GIST, etc. And a wide spectrum of ocular side effects are reported, but usually they occur within the first 3 to 6 months of starting imatinib. And a lot of side effects, especially fluid retention like symptom like periorbital edema and papilledema, retinal hemorrhage can occur, which are more unlikely. The retinal glaucoma, papilledema are more unlikely in this case. And from our case, we can find that imatinib-induced optic neuropathy can occur at any time after initiation of treatment with this drug, and it can be either passive edema due to fluid retention in the connective tissue or extracellular matrix and inhibition of platelet-derived growth factor receptor, or it can be due to optic neuritis. And different mechanisms may be at play simultaneously, as in our case, where the initial episode was undoubtedly optic neuritis, as evidenced by the VEP, MRI, and the visual field changes, and mandated treatment with steroids along with cessation of imatinib. But the second episode could have been a passive edema, as the disc edema resolved just by stopping imatinib. So whatever be the reason, the first step in the management of a patient on imatinib presenting with vision drop is withholding of the drug. But it is important to rule out other intracranial cause of optic disc edema, like demyelination, leukemic infiltration of the CNS, cortical venous sinus thrombus, etc. in a patient with CML before imatinib-induced optic neuropathy is diagnosed. These are my references. Thank you.
Nice presentation. And imatinib, you said induced optic neuropathy is because of inflammation then. What is the reason behind? I mean,
it can be, ma'am, optic neuritis is reported, and optic neuritis, the reason, it is a side effect that is very rarely reported with imatinib, or disc edema can occur also due to fluid retention, which can occur with treatment of imatinib. Generalized fluid retention can occur, and even optic nerve disc edema, fluid retention can cause this disc edema.
And it affected one eye, not both eyes?
In this case, only one eye. In literature, both eyes has been reported.
What is the percentage imatinib affected?
Very less, ma'am, very less.
What was the cause of your patient actually? I just came now, so I just wanted to know what was the, why the patient was on imatinib?
He had CML, ma'am.
Huh?
Chronic myelogenous leukemia.
Okay, so can other things be also a cause? Just thinking that can the drug be one of the effect? Can you think of any other things which can be also affecting it?
Ma'am,
because did you just because that is also one of the side effects of a drug, but usually we don't take it. Some other things we are focusing on initially. So what are those things will come to your mind first than thinking of
imatinib?
Yes.
Yes. Initially, we thought it was just another idiopathic episode of optic neuritis, unrelated to the drug, and we treated as another just a case of optic neuritis, the leukemic infiltration of the optic
that is
nerve.
what I am saying.
Yes.
Can it also be a
Yes.
like how long was the patient under treatment? Can it be a infiltrative type?
Yeah.
So did you think about in those terms?
Yes, ma'am.
And then when you stop it, because you have to follow up these patients.
Yes.
So once you are stopping this drug, yes, drug effect you are saying. So maybe you are seeing an improvement.
Yes.
But these are very dicey things. They are under longer follow-up. So are they going to change on the drug or regimen, or because if again it recurs back, your disc edema. So what are you going to give your opinion to your oncologist, how they will be dealing with it and all?
We thought of tumor infiltration initially
Yes.
as a part.
So
we took
you must have done some protocol, some test for those things.
Yes, we did an
Yes.
MRI. The patient was on remission. At that moment, the patient was on remission. But tabinatinib is a lifetime drug. It has to be continued.
Yes.
And the patient has been on the drug for 6 years. There was no, the blood picture was normal at that time. And we did an MRI. We looked for any feature of tumor infiltration of the optic nerve or in the CNS anywhere. But nothing was there. Just there was enhancement of the optic nerve.
Sometimes patients are there long term. You see some lymphoma patients and all are there, and long term treatment also they are there, and under treatment also there is a recurrence of this optic edema, disc edema, which is there, and it is usually unilateral things.
Yes.
So sometimes you have to be also taking those into consideration, thinking that if the vision is dropping, then you have to be very careful in giving also some intravitreal things, which also goes in the long run.
Okay,
So this is something there.
Okay.
So this drug is a effect, you had it, but can it be a infiltrated thing? Should be always a differential.
Always, yes. No.
Okay.
Good morning, everyone. I'll be reporting a case. Actually, it is not atypical also. It is suspected optic neuritis following ATT. I am presenting a case who was 44-year-old male who is a teacher by profession and came to our OPD on last year in the month of December. And his chief complaints were sudden diminution of vision in both eyes for last 1 week. It was associated with dull pain. Initially, he observed blurring of vision in one eye, which was followed by involvement of other eye also within 2 days. Diminution of vision was gradually deteriorating. The past history of the patient is very significant. He's a known diabetic for past 10 years, and he had a bout of hemoptysis. And within 10 months, he had 2 bouts for which he was investigated. The right lung upper lobe cavitational lesion was diagnosed in June 23, for which the specimen was taken from wedge of the right upper lobe, and on histopathological examination, the specimen did not reveal anything related to tuberculosis, and there was no evidence of malignancy also. But he was diagnosed as necrotizing granulomatous inflammation of the lung, and for this, he was put on ATT as per the DOTS regime. The patient is also on oral hypoglycemic drugs, and once he was put on this oral ATT for his lung lesion, though none of the investigations revealed that he had tuberculosis, which he continued till 20th of December last year, but he developed these visual symptoms on about 10th of December last year. But still he continued with the treatment because he was told to continue it for 6 months. When he presented to our OPD, on examination, his visual acuity in the right eye was 6/36, whereas in the left, he had dropped to 6/24 part, and this was the best corrected visual acuity. Extraocular movements were slightly painful. Color vision, he had red-green hue defective color vision, and the contrast sensitivity was also slightly reduced. Anterior segment examination revealed he had a nuclear sclerosis of grade 2 with blue dot cataract in both the eyes, and intraocular pressure with AT was 14 and 16 millimeter in both the eyes respectively. Fundus examination revealed hyperemic disc and tortuous vessel, and he had background diabetic retinopathy in left eye. Investigations like OCT, optic nerve head, retinal nerve fiber, which was performed, were inconclusive. MRI brain with orbits was done, and it suggested small vessel disease indicating ischemic insults. His vision continued to drop till it was 2/16 both the eyes, and he was advised other investigations also like B12, TSH, NMO, and MyoG antibodies to rule out any autoimmune pathology, calcium, phosphorus, ALP, SGPT, lipid profile, urea creatinine, etc. ESR was also on higher side. So it was around 48 millimeters first hour. Blood sugar fasting and postprandial was within normal range, slightly on higher side. So the serum triglycerides were on higher side, and rest all the investigations were found to be within normal limits. There was no NMO or MOG antibodies found. These are the OCT pictures of the same patient, which were performed at frequent intervals, and they were almost inconclusive on different durations of his illness. And then he was put on treatment once he did not improve, even around 6 weeks after the stoppage of anti-tubercular drugs, and he continued, his vision continued to drop till it was 2/60, and after performing all these investigations, we started him on pulse steroid therapy. IV soluble Medrol 500 milligram for 5 days. He was put on IV. Then it was tapered and he was put on oral Visolone tablets 40 milligram, 30, 20, 10 and 5. And when the duration of this oral steroid treatment was continuing, he was simultaneously he was put on injection insulin also to take care of his hyperglycemic status. And once the treatment was started, his vision started to improve, and by the end of 3 months, his vision was around 6.9 parts, best corrected in both the eyes. Intraocular pressure and other details were within normal limits. So the provisional diagnosis of atypical optic neuritis was made. But there was a sudden twist in this patient. He used to come for regular follow-up, and once he came for follow-up last month, his vision, though his vision was, best corrected vision was still on 6.9, but his intraocular pressure was on higher side in both the eyes, and fundus examination revealed temporal disc pallor. Perimetry was normal, and follow-up OCT also revealed temporal thinning and retinal nerve fiber thinning also. And after this, now the patient has been put on anti-glaucoma therapy. This is the picture which is recently done at 6-month follow-up OCT revealing temporal thinning. So these are the references, though I have labeled him as atypical optic neuritis, but still I am not sure about the correct diagnosis in this patient. Thank you.
OCT, nice presentation.
Thank you.
OCT macula you didn't do?
That is normal, that we did,
That
but
was
I have
normal.
not presented the pictures here.
And field test you should have presented also.
Actually, I was not able to upload that at the last moment. That is also normal. I have seen
From the beginning it was normal.
Yeah. Perimetry throughout has been normal, only we have been
No,
following
vision
him.
was reduced so much,
Yeah.
can't be normal.
Yeah. No, that time it was not done, but regular follow-up once his vision started improving, when, as I told you, he was on steroid, and all these tests were within normal limit, but once he came for follow-up at his around 6 months, this
It was
OCT,
normal. So,
yeah.
Okay. What was the reason typical neuritis? Cause, what do you feel?
Previously, we thought it may be perhaps because of ATT, especially ethambutol. But since he has developed this optic, this disc pallor also, he's going, the shift is towards glaucoma now. So it may be some other causes of optic neuritis, which is even not fitting into atypical type. So we are planning.
Patient has ATT, you are saying, so ethambutol, how long was he on ethambutol? So
He was on 6 months, even though he started with visual symptoms, but he did not stop because he was told by those lung people where he had got those investigations for his lung biopsy and all done. They had told him not to stop before 6 months.
Okay.
So even though he developed visual symptoms, he did not stop that.
So can it be a ethambutol toxicity which you saw
Yeah,
in
that
this?
is what I told you. We did
yeah.
not start him on pulse steroid till 4 to 6 weeks. We waited after stopping ethambutol and other ATT drugs, and we waited that perhaps if it is due to ATT, his vision should have improved. But on the contrary, it further fell to around 260 in both the eyes. So
Because
after that,
ethambutol toxicity is always there, so there will be a fall in the initial visual in those cases. So
But that is what I told you, ma'am. Initially, we did not put him on oral steroids. We waited for some time, but still, when the vision started to deteriorate after that, also it deteriorated to 2/60. At that point of time, after getting all those investigations, and we tried to rule out neuromyelitis and other autoimmune optic neuropathies, and then we put him on.
did you do MOG and all in this stage
Yeah, I have
also
referred to that,
associated?
ma'am. They were all normal.
All normal. Okay.
Okay, thank
Thank
you.
you.
Thank you.
Nice presentation. So next, sit down.
Good
In
morning,
case of
everyone.
okay, go ahead.
I will be speaking on a rare case of bilateral optic neuritis as presenting manifestation of lymph node tuberculosis. ये आगे नहीं जा रहा है. हाँ, sorry. A 23-year-old lady presented to us with history of sudden onset diminution of vision in the right eye since 4 days. The vision at presentation was PL denied in the right eye. There was no history of headache, vomiting or altered sensorium. There's no history of redness, pain or trauma. There was history of malaise for 15 days with progressively increasing painful swelling over the right neck. Other than that, she did not have any significant positive history. There was past history of neck swelling in the right side, which had subsided with oral medication 4 years back. For 1 week, she has taken the medication. And there's also family history of tuberculosis in the husband, who was on ATT 1 year back. She is married and had has two children, 7-month-old twins. There was no high-risk sexual behavior or any other history. There was no any addictions or any history of consumption of toxic substances. On examination, the patient was thin-built, afebrile, there was pallor, and cervical lymphadenopathy was positive. There were no positive systemic findings on examination, including the nervous and respiratory system. However, on local examination, we saw that there was a 5 centimeter into 5 centimeter mobile nodular swelling over the submandibular region with mild tenderness. So the visual acuity was PL negative with PR inaccurate in the right eye. The left eye had 6/12 to 6/9 vision with pinhole. Other than that, everything was normal except for RAPD in the right eye. And on the fundus photograph, there were disc margins were blurred and raised with tortuous vessels. In the left eye, there was a splinter hemorrhage also. So this is the photograph we took with 20D. This is the picture of the left eye. You can see the disc margins blurred with splinter hemorrhages. So the differential diagnosis which we made was papilledema or bilateral optic neuritis. So on investigating her further, since the chest x-ray and everything was normal, we went ahead with the FNAC of the submandibular lymph node. It came positive for tubercular lymphadenitis. So since the patient was young and feeding and like she had 2 babies and PL adenide, so we started her on injection methylprednisolone 1 gram IV infusion over 30 minutes for 3 days, followed by oral prednisolone. She was also given tablet levofloxacin, and after FNAC report, we started her on ATT. So the visual acuity was not improving, but she was PL positive at the end of day 3. So this is the fundus picture showing day 3. You can see the disc edema has resolved dramatically. At the end of 2 weeks, she came back and her vision had improved to 6/9 in the right eye. The left eye remained 6/9. And as you can see, there was no RAPD present in the right eye. So my take-home message is that initially what we were thinking is that if the patient is PL denied, we should not do anything like that. So in this case, I saw that a PL denied patient can regain near normal vision. So that's why I presented this. And optic neuropathy in TB, in our case, probably we thought that it is because of tubercular perineuritis and has varied manifestations. Bilateral optic neuritis has not been described. Bilateral optic atrophy has been described. So this is these are some of the references which I saw. So in this, they have described that papillitis is the major cause of optic neuropathy, followed by neuroretinitis and some cases optic nerve tubercle. So my only point which I want to stress is that visual recovery from tuberculous optic neuropathy is common, and if the diagnosis, you can clinch the diagnosis and give the treatment immediately. This is my personal thing, that they gain vision fully. Thank you, ma'am.
So
Yeah, nice.
the thing is that when you are dealing with actually tuberculosis, and they come with a lot of varied spectrums of ocular manifestations.
Yes,
So clutching on that, you didn't have anything except this optic disc edemas in both the eyes. That is what there was a RAPD in both the cases. And you are saying that starting immediately with ATT.
No. We first started her on steroids because the patient was PL negative. So we started on steroids
without doing ATT testing also.
No. ATT testing was sent. So at the end of 3rd day, the report came positive. Then ATT was started.
Okay.
So before that, we have already started steroid, thinking that we have nothing to lose.
Yeah, but in tuberculosis, you have to be very careful to do other tests because we just cannot give on ATT in all cases when you see a bilateral disc edema, even though the vision is lost. When you are already suspecting that this case can be a tuberculosis, if it is a pulmonary tuberculosis?
It was not pulmonary.
Okay.
Cervical lymphadenopathy was there, and FNAC had.
So did you do a chest X-ray
Yes,
and then
ma'am, yes, ma'am.
CT and all this?
Yes,
so
ma'am.
there was
MRI was also normal actually.
so
Uh-huh.
that is why it is like
Yes, yes,
you're
ma'am.
having it
Yeah.
can be a atypical presentation, but has to be very careful because if the patient has a pulmonary TB and you just start on there
No,
can
ma'am, we have
yeah.
taken reference from medicine people. They have
Okay,
seen, and
okay.
then with their like cooperation.
Okay, so
and
you are
everything,
following
yes.
it this,
Yes.
but
So
can you say that it was only your pulse therapy which helped, or giving them the ATT, and there has to be some
Yes, ma'am.
pulmonary thing going on, because extra pulmonary only did it help it to gain
Ma'am,
its vision
I-
back when he is having only PL negative? This is one point I just
Ma'am,
want to stress.
ATT will take some time to work.
Yeah.
So by the end of third day, जब हमने ATT शुरू किया, उसके पहले उसका PL positive हो गया. She could see some kala things and all. So that's what she was telling. So that's why I thought.
No, it's okay. So how, like giving your pulse therapy, she regained back immediately?
Not immediately,
Yeah.
ma'am. It
So
took
you-
time. It
so
took
how
her
long
2
did it
weeks.
take?
2 weeks.
2
She
weeks.
came to us
and that
after 2
time
weeks.
you had started your ATT also.
Yes, ma'am. She was under ATT.
Okay.
You mentioned about the disc finding of the left eye, right?
Yes,
eye you
ma'am.
didn't show.
Right, I also have shown, ma'am.
Shown. Okay, fine.
I've
Maybe
shown,
I
ma'am.
might.
Thank you,
Okay, nice presentation.
Thank you, ma'am. Thank
Thank you. I think any. So she will be presenting about asymptomatic contralateral inferior quadrantopia when glaucoma is damaged is not glaucoma.
Yes. Good afternoon, respected judges. My topic of my case is asymptomatic contralateral inferior quadrantinopia when glaucoma is damaged is not glaucoma. So, first of all, let us know that neuro-ophthalmic conditions can present asymptomatic with disc changes suggestive of glaucoma. So, the prognosis can be improved by preventing delay due to unnecessary treatment with anti-glaucoma drugs. Here I am to report a case which was misdiagnosed as glaucoma elsewhere, but our careful evaluation led to the salvation of the visual acuity. So, coming to the details of the case, it was a 53-year-old male with a positive family history of glaucoma. He had a complaint of occasional floaters with a positive history of stroke, and he was known case of hypertension. On ocular examination, both eyes, the BCVA was 6/6 and color vision was normal. Corrected IOP we found was less than 21 millimeters of mercury in both the eyes. However, the CCT was on the higher side. Around 560 microns. Pupil was central circular, direct and consensual reflexes were present in both the eyes. On fundus examination, the cup disc ratio appeared to be around 0.7:1, but the NRR was healthy and other signs were not present suggestive of glaucoma. So we were thinking of physiological cupping. We did an OCT RNFL which showed superior defects in the right eye and temporal defects in the left eye. The patient was suspected as a normal tensive glaucoma and he was already on eye drop timolol 0.5% BD from outside. He came to us for a second opinion. We advised for an HVF field analysis and we found a typical contralateral inferior quadrantinopia in both the eyes. So this was not suggestive of any glaucomatous field defect, rather it was suggestive of any underlying neurological disease. So further course of treatment, we advised for neurological consultation. MRI brain plus orbit with 2 mm optic nerve cuts was done. It showed left parietal region calcified granuloma. So the anti-glaucoma medications, they were stopped and neurology and patient is being followed up under neurology now. So the take-home message is not all cases are glaucoma. When to suspect that it is not glaucoma? If the patient comes with a complaint of decreased central vision or defective color vision, RAPD is present, or if there are absent disc hemorrhages, the disc pallor is more than cupping, if the visual field defects are respecting the midline, and if there is a poor disc to field correlation, then we have to suspect any underlying neurological disease other than glaucoma. Thank you.
Okay. It was a good presentation. The thing is, your previous ophthalmologist who has seen this case has done a OCT, has not done a visual fields and started on anti-glaucoma.
Yes, ma'am.
So that is what something has to be stressed on, because when you are starting anti-glaucoma medications, or when you are saying that this is a glaucoma or NTG, so fields was not with the patient.
No, ma'am. He only
So-
had
so-
IOP.
So
Yes,
that is what the thing I am stressing on. So the full workup was not done. Maybe the patient presented to you earlier, and you have done a very definitive thing of going ahead to do a visual field, which was missing in that case.
Yes.
So even there also it could have been picked up.
Yes, ma'am.
If it would have been done, because they just did a OCT and they took the IOP reading and started
Yes,
on
ma'am.
medications.
Yes, ma'am.
So that message should be gone.
Also, ma'am, the CCT was on the higher side, so it overestimated maybe the
Yes,
IOP.
Yeah,
yes,
right.
that is the
That's-
thing.
that's
So they had not fully completed the things. They should have done a visual field, and they could have picked up there only the case.
But anyhow, you have managed well.
Thank you.
Good presentation.
Thank you.
Thank you. So any